Subacromial bursitis. Subacromial bursitis is a condition caused by inflammation of the bursa that separates the superior surface of the supraspinatus tendon, that is one of the four tendons of the rotator cuff, from the overlying coracoacromial ligament, acromion and coracoid, that is the acromial arch, and from the deep surface of the deltoid muscle. Causes. This condition is typically caused by excessive use of the shoulder. Occupations such as painting or construction, which require repetitive overhead motions, are common culprits. These motions irritate the bursa, causing it to become inflamed. Pathophysiology. The literature on the pathophysiology of the bursitis describes inflammation as the primary cause of symptoms. Inflammatory bursitis is usually the result of repetitive injury to the bursa. In the subacromial bursa, this generally occurs due to microtrauma to adjacent structures, particularly the supraspinatus tendon. The inflammatory process causes synovial cell to multiply, increasing collagen formation and fluid production within the bursa and reduction in the outside layer of lubrication. Case history. Name: Shireen Afzal, age 35 years, ward OPT, gender female, occupation factory worker, address Jinnah Colony, Lahore, presenting complaint pain in right shoulder, onset 1 week ago, comorbidity none. Aggravating factors: pressure or any household task which puts stress on shoulder and elbow, pain tender to touch, social history middle class, general health status, expressions normal, blood pressure 135 by 85 millimeter mercury, blood pressure temperature 97 degree Fahrenheit, growth and developmental history normal, nutrition and diet normal, healthy diet and no addiction. Assessment: special test to differentiate a bursitis from a supraspinatus tendinopathy, which are often confused. A therapist can perform a test to isolate the supraspinatus muscle. The patient abducts the arm to 90 degrees with the elbow extended and arms internally rotated. The arms are placed 30 degrees anteriorly, that is in the coronal plane, and the patient resists as the examiner forces the arm downward. This is often referred to as the empty can test. Frozen shoulder is another medical condition which can be confused with bursitis. In this case, the symptoms can be differentiated with an easy test. If the patient cannot abduct the arm, that is glenohumeral abduction, this means the patient has a frozen shoulder. The downside of this test is that it can only exclude adhesive capsulitis, but it does not necessarily confirm bursitis. Patients with bursitis and tendinitis presentations have normal muscle power, while patients with cuff tears can be distinguished by loss of power, pain in the C5 dermatome, and painful arc during elevation. The subacromial deltoid bursa comes with conflict with the acromioclavicular joint dysfunction, positive painful arc, that is pain between 60 and 120 degrees of abduction, indicates subacromial deltoid bursitis. To test the painful arc, the patient stands up with arms alongside the body, then actively abduct the shoulder from 0 to 180 degree. Test is positive when the patient complains of pain between 60 to 120 degree abduction. The pain results from the compression of the supraspinatus tendon and subacromial bursa in the subacromial space, which becomes narrower at this range. Beyond 120 degree, the pressure on the bursa decreases and the pain is lessened. Differential diagnosis: adhesive capsulitis, rotator cuff tear, supraspinatus tendinopathy, subacromial bursitis. Diagnosis: subacromial bursitis. Plan of care: pharmacological treatment. Number 1, non-steroidal anti-inflammatory drugs. Number 2, gel for pain relief, that is in which active ingredient is salicylic acid and mucopolysaccharide polysulfate. Therapeutic treatment: ultrasound, phonophoresis, iontophoresis. Exercise protocols: 4 to 6 weeks no overhead abduction. 1 to 3 weeks isometrics. After 3 weeks, range of motion exercises within 90 degrees. After 4 to 6 weeks, slowly gain range of motion and strength, shoulder joint mobilization and scapula mobilization, resisted exercises. Thank you.